Now we're going to see the Leymioma, also called fibroid. Here the patient has masses on the uterus. This is usually a pedunculated, like Leymioma. It could be pedunculated if it is subserous. So it could be subserous, submucosal, or intramural. So this depends where on the uterus. So here we have the uterus. Something like this. Remember, the serous is the outermost layer, so it could be subserous, just beneath the serous, just beneath this submucous, or intramural. So here, the subserous are usually pedunculated, and because they are pedunculated, they could be like if this stalk is cut, these fibers can go to the peritoneal cavity, and these are called fibroids. That's traveling. They could also be on the cervix or ovary, etc. There could be also ischemia due to torsion, for example, of the pedunculated Leymioma. This would be a emergency, and the patient needs narcotics at this point and be hospitalized. They could also undergo degeneration. The degeneration could be a cystic degeneration, mucinous degeneration, red degeneration. The red degeneration is a coagulative necrosis on a hemorrhagic surface. Then the clinical presentation for a just normal Leymioma is most of the time asymptomatic. The patient could have pelvic pressures due to this pelvic mass that could lead to urinary urgency or urinary retention, constipation, pain at defecation or dyspareunia or dysmenorrhea, also heavy menstrual bleeding. And Leymioma is the most common neoplasia of the uterus, and is seen most of the time on premenopausal women, with increased incidence on African American women. This rarely would convert to a leiomyosarcoma. Leiomyosarcoma would be a malignant proliferation, but that the leiomyosarcoma usually arises de novo. This is proliferation of the smooth muscle cells, and histologically we will see a worded white appearance, and usually we have multiples of them. You will see a enlarged uterus and asymmetric uterus, non-tender uterus. Remember, there are 4 causes of enlarged uterus: pregnancy, leiomyomas, adenomyosis, and the endometrial cancer. The pregnancy we should always exclude it with a PHCG. And then we can do a ultrasound. The vaginal ultrasound is better for the subserous and intramural ones. And we can use other methodologies like MRI, but these are used most of the time for preoperative basis, things like that, even though this is the most powerful. We can also do a ultrasound, a silent infusion ultrasound for these to localize the submucosal ones. Now for the treatment, the leiomyomas are estrogen sensitive, so they grow, for example, in the menstrual period when they increase estrogen, and they regress, for example, in the menopause. They increase in pregnancy, things like that. So one thing that we can do is give GnRH antagonist. So there will be decrease in the size, and because there is decrease in size 1, we are controlling the bleeding, so less bleeding. And also there will be, for example, we can now do a vaginal hysterectomy instead of a abdominal hysterectomy, so it would be better. The bleeding that can occur at the surgery, so it's very helpful to give these drugs before the surgery. We can use these drugs, or also medroxyprogesterone and danazol are used for control the heavy menses. And the treatment will depend, for example, if the patient has completed the childbearing age. So if the patient does not want to continue fertile, we will do a total or subtotal abdominal hysterectomy or vaginal hysterectomy. Or we can do arterial embolization. Here we are preserving the ovary here, but this does not guarantee that the patient could become pregnant after this. Here you will get insight from the pelvic vessels, then you will go to the branching of the aorta at the end to the internal iliac artery, then to the uterine artery, that is the one branch of the internal iliac artery, and then you embolize there. And you should be very careful to not embolize other vessels like the one of the ovary, because this can lead to premature ovarian failure, things like that. For patients that are not that don't have completed the childbearing age, we could do only a myomectomy. This is just the removal of the Leymioma. This could be a vaginal or transvaginal myomectomy, or hysteroscopic myomectomy. Remember, this would be very helpful if we first give the GnRH antagonist.